Yeah.
Yeah, well, Mercury and Becquerel are, but they're technically like those two. Yeah, the Curie is the special, and the Becquerel is the special. So I just remembered them by so Rockin, Ram, and then the Curie, and the other ones, Gray, Cedar, Becquerel.
Well, there's two varieties, you know.
Well, no, this is a different. This is in regards to air karma. In air karma, think about like how it's measuring. It affects the absorbed dose, and so how like it's measuring how much it's in the air. Yeah, that was kind of weird. But I just remember like just memorizing the special units and SI units. That's how I did it.
If you're following along in the PowerPoint, we're starting on slide 54 with rheumatoid arthritis. So rheumatoid arthritis is a systemic autoimmune disease. This is where the autoimmune system attacks the synovial membrane in the joint space. That synovial membrane is actually a connective tissue membrane that lines the capsule around the joints and helps secrete that lubricating fluid so that the joints move easily. It is a very persistent and progressive disease. However, there may be some remission. Essentially, in this disease, what happens is the autoimmune system, the immune system, attacks that synovial membrane, creates inflammation in that joint space, which increases the fluid level inside that joint space. It then causes granulation of the tissues, which then causes erosion of the bone and the cartilage. And then it can lead into ankylosis, which is essentially a fusion of the two bones in that joint space. So if we're looking at the fingers, in this instance we're looking at the hands here, so it actually fuses the digits together rather than it does lead to joint deformity, as you can see in this top picture. That's actually the beginning stages with the inflammation in the joints. And then here, everything is kind of fused together, so the hands are then deformed, and the fingers actually don't move at those joints. Usually starts in the small joints, so typically in the hands, sometimes in the feet, wrists, and then it can move into the trunk of the body, where it gets to the ribs, clavicle, larger long bones, things like that. So here, it's kind of a cross-section view. So here's the bone, so this is just a frontal plane of your finger, essentially. So here's the synovial membrane, highlighted in red. Here's that fluid in that joint space that's there to help reduce friction in the joint and in the articular cartilage. In rheumatoid arthritis, that synovial membrane becomes inflamed and then produces excess fluid. And then that excess fluid can actually eat away at the normal cartilage, causing pitting, and then eventually it completely wears away, and then you have that bone on bone, and then with the ankylosing fusion. As I said, it usually affects joints symmetrically. So if you're going to have it in one wrist, it's going to be in the other wrist. It's not just unilateral. You usually have it on both sides. As I said, it starts in the smaller bones, smaller joints, and then moves its way to the thorax. So frequently it will attack the wrists, the elbows, the shoulders, the knees, and the ankles. So who's really affected? Women are more susceptible than men. Unknown as to why. They think it could be the difference in hormones between men and women, but it's really an unknown setting. Usually at about age 40 is when it is an onset, and there is some links to reproduction, where it can be pass on. So here, the swelling at the joint, you can see all the soft tissue swelling on these x-rays here. You can actually see here, some of it actually looks like it's already starting to fuse together. The first digit here. You can see this is actually subluxed. Again, here it's starting to fuse. The wrist, you see all the swelling there. So side by side, normal hand with rheumatoid arthritis, you can see the bone erosion, narrowing of the joint spaces, bone displacement. And here you can see the deterioration of the bone, as well as osteoporosis in the bone, and then all that displacement as well. So late stage, you can see what's termed the boutonniere deformity in the thumb. Ulnar deviation of the metacarpophalangeal joints, what we term the swan neck deformation of the fingers, because it almost looks like a swan's neck. And there's the x-ray. See, it starts off with the swelling. You have these multiple nodules around the joint space. So another form of rheumatoid arthritis, you end up with ankylosing spondylitis. Typically begins in the SI joints bilaterally and then moves its way into the lumbar spine. It just begins as with the hands and smaller bones, an inflammation in the joint space. That leads to the narrowing of the joint space, where that cartilage inside the SI joint starts to harden, and then eventually causes fusion of the pelvis, the iliac, to the sacrum. Then progresses up into the lumbar spine, where the vertebrae then fuse together, causing what we've known as bamboo spine. See some pictures of that in a minute. Limited activity due to this also leads to osteoporosis. Bones start to deteriorate as well. Ankylosing spondylitis actually affects more men than women.
You said that there would be initial rheumatoid arthritis though in the extremities that can move to this. Correct or no? This is
So normal rheumatoid arthritis typically moves into the thorax. So ankylosing spondylitis starts in the SI joints and then moves into the spine.
okay. And it wouldn't move to the extremities either, just on the side.
Typically. I mean, if someone has rheumatoid in the hands, then they are more susceptible than ankylosing spondylitis, but they are separate. So here you can see that narrowing and some sclerosis of the SI joints in an AP image. Here's that bamboo spine I was mentioning. So here in this little off-center picture is a normal spine. Now you can see how everything is kind of fused together. And side by side, it looks like shoots of bamboo. And here it is in the neck. You can see how it's all fused together. So Reiter syndrome is another offshoot of rheumatoid arthritis. This is also known as reactive arthritis. It's usually developed in response to an infection from another part of the body, usually bacterial. It's triggered following either enteric or urogenital infections or venereal diseases. It involves arthritis, conjunctivitis, and urethritis. The inflammation is also triggered by some mucosal infections. This typically affects younger men. So some causes could be chlamydia as a venereal disease, or like a GI infection could be like salmonella. This could be an offshoot of that. Usually affects the SI joints, mostly bilateral, but sometimes asymmetrically. Also the heel and the toes. It can also involve skin psoriasis, which are like skin lesions. So here you see erosion of the Achilles tendon insertion point, and also the plantar fascia insertion. Here is that retrocalcaneal bursa erosive disease due to Reiter syndrome. So you can see how it's kind of eaten away at the calcaneus. So again, destruction of the joints and the foot. See how that's subluxed. These are all shifted over. So now psoriatic arthritis is another form of rheumatoid arthritis, or related to rheumatoid arthritis, I should say. Mostly affects the distal fingers and the toes. It can affect the spine in more severe cases. Typically, it's just going to be fingers and toes. Usually will include psoriatic skin lesions. That's what all this is on the hand here. It can see asymmetric bone destruction as well with this. So here's what we term the pencil in cup deformity. And then also you see that ankylosing here. In the first digit. So you can see some bony proliferation and erosion. So you see how it's eroding and eating away at the bone here. Starts with a little bit of erosion around the edges, and then eventually here, see that pencil in cup deformity as well. So you also see some asymmetric ossification. As you can see here in the spine, how you have the bone retreating over and molding itself to the spine wall. Osteoarthritis essentially is a loss of joint cartilage. So as you see here, this is a healthy knee, cartilage on both the femur and tibia. Here, in osteoarthritis, it starts to become more ways. See some atrophy and spurring of the bone and erosion of that cartilage. It is the most common joint disorder, affecting roughly 20 million people in the U.S. It's generally due to wear and tear over age and use. So as you get older and use your joints more, this is more common. The weight-bearing joints are most susceptible, where you're going to have the spine, the hip, the knees, the ankles. Can also lead to septic and inflammatory arthritis. Essentially, you're going to have a breakdown of that hyaline cartilage in the joint space, which can then lead to the synovial breakdown and then eventually that bone erosion. So the cartilage is a firm and rubbery tissue. I don't know if any of you did cadaver lab for A&P. If you remember dissecting through any of the joints. It's kind of a rubbery substance that's the joint space. That's that hyaline cartilage. It essentially cushions all the bones at the joints and allows the gliding. So if it's not there and it erodes away, your bones won't move. You'll have a lot of pain trying to bend your knee or sit down or things like that. It can then lead to bone spur formation. So if you can, I don't know if you can see on this picture here. So kind of this little edge right here, and even up here, those are termed bone spurs. And those can actually end up, when you move, poking into the ligaments and the muscle tissues and cause a lot of pain that way as well. So some instances, as we say, it's an occupational risk. So if you do a lot of kneeling, squatting, lifting, stair climbing in your occupation, or if you do a lot of sports like professional basketball, football, soccer players, or if you've done it for a long time throughout your life, played any of those sports, you can also be more susceptible to this. So radiographically, what we're going to see is a narrowing of the joint space due to that thinning of the cartilage. You can also see bone spurs, or what we term osteophytes, around the edges of the bones. Can also lead to subluxation as a result of the weakened joint capsule and ligaments. We'll also be able to see what we term joint mice. So all these little pieces of bone, those are called joint mice. And the hips, you're going to see some narrowing superiorly and laterally. And the narrowing will be at the points of the greatest weight-bearing stress. So the knees, you're going to see that the femorotibial joint. So here, healthy knee again, have that articular cartilage surrounding the femur. You have the discs separating from the tibia. On an osteoarthritis, you're going to see that wearing away of that cartilage around the disc space is getting narrowed. Joint space is getting narrowed and worn away. It's going to end up with bone on bone. So here's an image of a left knee. You're going to see that joint space narrowing and that osteophyte formation. You're also going to see some spur formation on the edges here. So in the hand, you're going to see the narrowing of spaces in the interphalangeal joints with some fusion occurring already. Now you have this right hip joint space narrowing, as you see on the left side, nice and open and can be clearly seen. The right side almost looks like it's kind of overlapping. See that space being very narrow, pretty much bone on bone in this image. And here, this one's already been replaced, probably from the same issue. This one's about to be replaced, I would guess. You can see how that joint space is very narrowed. You can see some erosion in the bones, as well as excess bone formation around the edges here with some of those bone spurs growing. So infectious arthritis is a reaction to an infection somewhere else in the body. The infection then somehow gets into the bloodstream and then settles into the joints. It can come from bacterial, viral, or fungal infections. It can be associated with osteomyelitis or trauma. Also, pyogenic organisms can also get in there and start the infection as well. It is a very abrupt onset. There's usually no warning, if you will. It can also be migratory arthritis from Lyme disease. So erosion of the bone will typically take place about 8 to 10 days from onset of infection. Symptoms: you're going to have chills, fever, tender or swollen joints.
How many days till then? Sorry.
I'm sorry?
How many days till then?
8 to 10 from onset. Because we're going to see that bone erosion. Typically, if you have any of these symptoms and you go in and they suspect this, they'll probably run blood tests, urine tests. They may do aspiration of the joint fluid to run tests on that as well. Radiographically, you're going to see soft tissue swelling. In children, you're going to end up seeing a widened joint space and even subluxation. Also, you're going to see some narrowing of the space as that cartilage gets worn away. And that bone erosion, like I said, will take place about 8 to 10 days from onset. If it goes untreated, you're going to have a destruction of the outer layer of the bone, and then you're going to get that irregular bone growth. You can also end up with ankylosis. So here, you see this is the elbow. See there's really no joint space there. Bone on bone. You see some erosion and sclerosis in the humeral head. So you got some erosion right up in here. Right along this space in here. You also see that sclerosis right on here. So treatment for arthritis. The goal is to fight the infection that's causing it. Do a lot of drug therapy, depending on what the cause is, whether it's bacterial or viral or fungal. They may have to do surgery to do joint replacements, depending on how severe it has gotten, or even debridements to try to remove some of that infection out. It also depends on whether it's rheumatoid or infectious as to the other treatments that go with. Bursitis is essentially just an inflammation of the bursa. So the bursa is a small fluid-filled sac in most joints that helps reduce friction in the joint. It usually lies between the joint space and the tendons. They are lined with synovial tissue, which then produces that fluid to help lubricate and reduces friction when these structures move together. It will occur when the synovial lining becomes thickened and produces excess fluid. Will lead to localized pain and swelling depending on where it's occurring. The shoulder, the hip, elbow, knee will be localized to wherever that bursa is being inflamed. Humans have approximately 160 bursa throughout the body. It is very common in the shoulder, and they are due to repeat physical activities. So if you're doing, like with the elbow, it could be a relation of tennis elbow. If you're playing a lot of tennis, or you're doing something that causes a lot of elbow movements. Same with the knee, doing something that causes a lot of knee bending, shoulder movements, things like that. Other causes could be trauma. Rheumatoid arthritis can also cause bursitis. Gout infections can cause bursitis in the feet. And then certain other infections, you talked about infectious arthritis, can also cause an inflammation of the bursitis. Radiographically, you're not going to be able to visualize it on X-ray. Sometimes there can be deposit of calcification in the tendons, but typically it's too small to visualize on X-ray. If they use ultrasound, they'll be able to see ill-defined edges of that bursa, similar to tendonitis, visually speaking, in ultrasound. They'll also be able to see increased vascularity to the area on a Doppler ultrasound, which also will give an indication that there's some sort of infection going on. Or inflammation. Treatment-wise, they can do aspirations to help remove excess fluid, to relieve the pressure in there. Do heat to also help dissipate some of that excess fluid. A lot of rest or mobilization of that joint to give it time to rest and heal. NSAIDs to help with the inflammation. Antibiotics if it is due to an infection. They can also do corticosteroid injections to help increase the amount of healing to the area. As I said, they can also do some aspiration, as you can see here, to remove some of that excess fluid. Maybe you can see the swelling of the elbow, or the knee, or the shoulder. Here you can see this is a very large calcium deposit in that tendon. So this one is actually visible on X-ray. Typically, you're not going to be able to see that. Here on ultrasound, this is the left knee with the patellar tendon. You can see that bursa fluid underneath the tendon. Rotator cuff tears. So the rotator cuff is a series of muscles in the shoulder that all kind of combine in one area to act to stabilize the shoulder. So we have the teres minor, infraspinatus muscle, supraspinatus muscle, and the subscapularis muscle that all run essentially to the head of the humerus and hold it in place and stabilize all of the movements of the shoulder. So here you can see the supraspinatus, subscapularis, teres minor. So radiographically, you're going to want to do arthrograms to see contrast spill out of the shoulder joint to see if there's any tears in those muscles. MRI would then be the modality of choice to visualize this, where you can see the rotator cuff in black, and the tears will show up as white. In ultrasound, you'll see the tear as in black. So here, as you can show the arthrogram, you can see the fluid spilling out around the head of the humerus, which it should not be there. So here in MRI, see the muscle groupings here. And here you can see that tear right. Again, tear of the muscle right here on MRI. On ultrasound, shows the tear right. So the knee meniscus is essentially the C-shaped discs, if you will, that sit between the femur and tibia. There are two pads, essentially cartilaginous tissue, that help disperse the friction in the knee joint. So meniscal tears are typically due to trauma. They can be caused by degenerative conditions, but you see a lot of sports players that have meniscal tears after undergo surgery for these tears. So again, arthrogram would be the best view X-ray wise. But again, MRI, we see the meniscus is black and the tear is white. And then the ultrasound would really just show any related tendonitis to the ear. So there's a few different types of tears in the meniscus. So you have the normal meniscus here, a longitudinal tear, the bucket handle tear where a piece tears off, but it's still connected on the other end. A flap where it gets torn off and you have a little flap hanging there. Transverse tear would be going transversely through the actual meniscus. And then a torn horn, essentially it's like a flap tear that's right at the end or the horn of the meniscus. So the MRI, the lateral views, you have your normal meniscus. You can see it right there. You have a tear, so you have a white line coming through here. That's the tear right there. So here another MRI. See the tear coming through right back where those pink here. Here's a bucket handle tear. Here, kind of hard to visualize on this. Scroll through. So treatment-wise, if it's a small enough tear, they'll probably just do anti-inflammatory meds and mobilization of the joint, let it kind of heal itself. If they're larger tears, they either will have to do surgery to completely remove that part of the piece that was torn off, or to try to surgically repair it if they can using sutures to sew it back together. Bacterial osteomyelitis is a reactive infection, typically caused by either a wound, surgery, bone fractures, foreign bodies, such as surgical plate insertion and infected. So kind of meeting osteomyelitis. So osteo is bone, myel means bone marrow, itis means inflammation. So it's essentially an infection of bone marrow, which then leads into the bone. So whenever you have an infection, essentially anywhere in the body, there's typically pus formation. Depending on how the body handles that, it can then turn into an abscess. So if you have an abscess in the bone, that leads to pus in the medullary cavity that then spills out, causing a raise in the periosteum, and then again breaking and then leaking into the rest of the body. This abscess then deprives the bone of the blood supply in the bone and product. Early treatment can help save the bone from destruction. However, since the bone is a very hard tissue, it's often resistant to antibodies, so it can be very difficult to treat. It can then spread throughout the body if it spreads to the bone from the infections anywhere else in the body. So in diabetic patients, essentially, if they have any sort of skin abscess, it can then get in the bloodstream and spread to the bone. So intravenous drug use is in diabetic patients, and then it can be after surgery or trauma. So we have a acute heterogeneous osteomyelitis, which essentially comes from the blood to the bone. In children, it will typically attack the metaphysis of the long bones. It will come from the staphylococci or streptococci viruses. Symptoms would include fever, localized warmth, and swelling to the area. You can see in this cross section. So it comes from the blood supply into the bone, then creates this abscess in the bone that eventually busts through the bone wall into the periosteum, and then can then break from there, leading to the rest of the body. Kind of. I mean, in the grand scheme of how things react, yes, but it's all so I don't want to say infection, but the inflammatory process can lead to this depending on what's causing it. So if the cellulitis is caused by a, let's say, for instance, someone gets infected, either don't clean the area well enough, or somehow they ink it bad or whatever, they then can get cellulitis in that area. Depending on how long it goes on for, it can get infected and then lead to possible inflammation. So cellulitis itself is not necessarily a cause for inflammation, but it can lead to that. So in adults, it typically will attack the vertebrae. Symptoms will include back pain, muscle spasms. So radiographically, in early stages, it's not going to be visible on X-rays because it will be so small and internal to the bone. Nuclear medicine, in early stages, we'll do the technetium-99 bone scan. So this is essentially you'll see an increased uptake to the site of infection, which then leads to an increased blood flow to that area. So radiographically, none of this will be visible until after 10 days of infection onset. So you can see some localized deep tissue swelling, some bone destruction. You can see that raised periosteum. You can start seeing some of that necrosis due to that blood supply loss to that area. So Doppler ultrasound, you will also see increased vascularity to the area of infection. CT will be used to help determine the size of that soft tissue mass, and also will help locate the presence of any abscess cavities that could exist. MRI can be used to check abscess formation, can also help exclude the possibility of cellulitis. So for chronic osteomyelitis, you can see some thickened bone, that irregular bone margin, a hidden medullary cavity, swelling, periosteocalcification, and then they'll also be using a three-phase radionuclide bone scan. So essentially doing it the same nuclear scan that we just talked about, except it's a three-phase system, or three-phase way of scanning it. And you'll actually be able to see this in all three phases. So osteomyelitis in the vertebrae, you'll see an erosion of the bone plate, loss of the edges of the bodies of the vertebrae. You'll see some destruction in the vertebrae. It also will affect the disc space and adjacent vertebrae. And again, CT and MRI will be provided visualized. Treatment-wise, they're going to use antibiotics to help treat the infection. They will then go in and do surgery to remove parts of the bone that are infected, and then do a bone graft to replace it. So it's typically a 4 to 8 week antibiotic schedule to help get rid of the infections. Surgery, they will remove whatever dead tissue is there, if it, whether it's just the bone tissue that is necrotic, or if it actually spread out of the bone into the surrounding tissues. They'll also help to drain that abscess as best they can. So here, this is actually a 13-year-old girl who presented with left basal and right apical staphylococcal pneumonia. You actually see the lesions in her lower leg. My guess is she then also started having leg pain during these x-rays. And they found the area of elevated periosteum. So what does that tell you? You can see this on x-ray. How long did she been sick with this infection? You're not going to see it before that. So again, same patient. Start seeing the necrosis in the bone, as well as that destruction. Okay. Got in the foot, you can see that periosteal. Doesn't see it very well. There's some periosteal elevation here. So here you can see the acute metavenous osteomyelitis. So see a very large swelling of the leg. Here as well. This is the actual wet scan. You can see the black area of the infection. So this is the initial image of this patient. This is 3 weeks later. See all the destruction in the humerus. You can see how destroyed this area of bone is. What bone do you think this is? You can actually see the tibia is pretty much looked like it was broken and then regrew, but this is all just destruction of the bone. And as it was being destroyed, it tried to regrow, so it actually regrow into the fibula, as well as here, they're fused together. It's like the fibula is actually broken too at some point, right? Like all grew together. We got some more imaging here, so you have the x-ray. See the new bone growth kind of sleeve around the old bone. We have CT. Essentially it's the same picture, just after the CT. We're going to go back real quick, talk about tuberculous arthritis, if I remember the slides back. So tuberculous arthritis essentially is a disease in which there's a pathological change to some tissue or organ of the body. It is a gradual onset. This will affect usually the spine, the hip, the knee. It's a very slow progression. Typically will be involved in one joint, and it will accompany lung tuberculosis. About 1 to 3% of all lung TB cases will end up with tuberculous outcomes. So radiographically in early stages, you're going to see some erosion of the articular ends of the bones. You're going to see some osteoporosis near the joints. You're going to see some soft tissue swelling in the area. You have the cartilage and bone destruction at the outside of the joint, late stages. You also see narrowing of the joint and that ragged cartilage in late stages. You'll see some of those bone fragmentation on opposing surfaces. So what we saw earlier, we talked about the joint lice. It's kind of what we're talking about here, those bone fragments that kind of pop off the end of that. So here is a soft tissue mass, right here in the elbow. Here you can see that fragment popping right there. It can also lead to ankylosing. You get a joint space pretty much gone. Very little here. So we'll actually start fusing back together. We'll go to tuberculous osteomyelitis. Again, this is an extension of tuberculosis disease. This is also called Patho's disease. This will typically affect the thoracic and lumbar spines. It will begin in the anterior vertebral body, and the infection will then spread across the disc space to the next vertebral body. It can cause soft tissue masses, which then lead to vertebral abscesses. As we know, abscesses will then produce pus, which can then cause all the same issues as we talked about earlier: osteomyelitis, deep periosteum, swelling, rupture, that pus leaking out. This also narrows the space between the vertebrae. So the disc spaces are over there. The infection can then spread very easily either between vertebrae or then get into the body and spread to other organs and tissues. This varies from bacterial osteomyelitis in that there is no new bone growth. So radiographically, you're going to see irregular bony margins. They will then eat away at the vertebral marrow. If untreated, you're going to have a lot of vertebral collapse. For nuke med, they're going to do a gallium bone scan, which then will determine the extent of tissue involvement. CT will then demonstrate soft tissue involvement and how much bone destruction there is. MRI will be able to visualize changes in the bone marrow, but it will be less specific than that gallium bone scan. Treatment-wise, they will do antibiotics to treat the TB infection. They'll also do antituberculosis drug therapy, also effective with that. The antibiotics will also help with that pus formation to help try to clear out all of that. They can do surgical fusion, either full spinal fusion or Harrington rod placement to give that spine more stability. So here's an MRI image that helps demonstrate the destruction of the vertebrae in the thoracic spine. here, this is an abscess in the paravertebral space. You can see the destruction of the vertebral bodies. Again here. See the destruction of the vertebral bodies between T10 and 11. So here's what we call a gibbous formation. And what that is just a term for a sharp kyphotic angulation. So here is kind of the initial discovery. You can see how this vertebral body pretty much is collapsing in on itself. Eventually, it will then kind of fuse together. And what you see at this point, this picture was taken a few months after this initial diagnosis. So here we have a 6-year-old female who for a month had swelling to her left hand. They couldn't really figure out why initially. They finally brought her in, they took an x-ray, and they saw the bone destruction in the first metacarpal. So about a month later, they went into surgery to fix this. My guess is they removed this and put in some sort of bone graft and then after they did that, 2-week follow-up, they did a chest radiograph that showed this girl with a right paratracheal lymphadenopathy, which then indicated that she had some sort of TB infection at some point. Discuss some metabolic bone diseases now. So, osteoporosis. This is essentially a failure to form enough new bone, and in order to there's too much old bone resorption. This is the most common bone disease. It's essentially a thinning of the bone tissue. This is a very gradual process, so it takes place over time. Women are more affected, with about 1 in 5 women over the age of 50 suffer from osteoporosis. So as we talked about earlier, this is a osteoclast and osteoblast impairment. So the body fails to form enough new bone after the old bone was reabsorbed. So you have clawed on the middle of the bone, destroying it, getting the calcium back into the blood, then Bob isn't building up enough on the outside, using all that up. It then leads to brittle and fragile bones. So you can see here, here's a normal bone matrix. Down here, and here's osteoporotic bone. We have more being destroyed in the middle, not enough being built back up on the edges. Cause could be caused by a drop in estrogen or testosterone levels, a decrease in calcium and phosphate. So in this instance, we have a nice straight normal curve of the spine. In an osteoporotic patient, we then have deterioration of the vertebral bodies, leading to not being able to support the body anymore. Symptom-wise, you're going to have bone pain and tenderness, be susceptible to a lot of fractures, as well as loss of height due to that vertebral instability. Radiographically, you will see this most common in the spine or pelvic area. You have an irregular pattern of bone density loss, what we term a picture frame appearance. You have the anterior wedging or compression fractures in the spine. You're going to get a spotty appearance in the skull. You have some density loss in the sella turcica and the dorsum sella. So imaging-wise, they're going to do a DEXA scan or a bone densitometry scan, which will then give a bone quality value, or what they term a T-score. So if you have normal bone or greater than -1 on the scale, you're in this green area. So from -1 to -2.5, they then term the patient osteopenia, and greater than -2.5 would be termed osteoporosis. They will also do quantitative CT, which helps accurately demonstrate the levels of bone mass. It also can determine the rate of bone decay. It is the most accurate. It is dependent on the trabeculae of bone and how they do their measurements. You'll be negative to doing quantitative CT as it is a very high dose of radiation. X-rays, they'll use to determine fractures. Treatment-wise, they'll do medication to help strengthen bones, calcium supplements, things like that. They can do hormone replacement therapy, as typically this occurs in women over 50. Most of the time it starts during menopause. So we'll do therapy to help replace some of those hormones that are not being produced anymore. We'll also do exercise to help build up the muscles and help build the bones as well as do a new diet to help increase calcium and vitamin D intake. So here are images of a DEXA scan. Kind of shows how they do their measurements. They have like the ROI boxes, and then it gives them a value for each of these. And calculates it to see where they would be. So this is a 68-year-old woman. You see her value is right up here. So she is in the normal range. 74-year-old woman. Her value here, so she is in the opposite direction. So again, here, the spine, and then here, and we have a chart below it. So here you can see that compression fracture with that wedging of the vertebral body. Here, you will see a compression fracture, and then what they've done is called kyphoplasty. Have any of you seen it done or know what it is? A lot of times they'll do it up in the OR suite. Sometimes they'll do it down in an IR procedure. But essentially, they drill into the vertebral body that is weakened or fractured, and they will essentially inject cement into it to keep it firm. So here you can see there's kind of a balloon. They blow the balloon up to re-inflate or re-expand that vertebral body. Then they will inject cement into there to help keep it shaped. You can see here that kyphoplasty is already done. This is a compression fracture, we'll probably go into here. You can see the skull, the dots of the skull like we talked about. Here is kind of like that picture thing. Unequal density between the posterior and the anterior skull. Osteomalacia is essentially a lack of calcium and phosphorus absorption in the bones. The failure of that calcium and phosphorus to deposit in the bone matrix is usually affected by vitamin D absorption in the intestines. That lack of vitamin D, that's either a lack of vitamin D due to diet or the body's ability to actually break down and absorb and use the vitamin. So vitamin D is necessary to help the body absorb and use calcium to build bones. It does not allow, so a lack of vitamin D won't allow the calcium and phosphorus to be absorbed in the bone. So that leads to a softening of bones. It also leads to rickets, or it's termed rickets if it's in children. As an adult, they'll call it osteomalacia. If it's in children, they'll call it rickets. There's slight differences between children and adults, but we'll talk about rickets a little bit later on. So the difference with osteoporosis and osteomalacia. So osteoporosis, as we said, was a weakening of previously constructed bones. So the bone's already there, it just then gets weakened due to the deficiency in calcium and lack of certain hormones and things like that. Where osteomalacia is an actual defect in the bone building process. And keep that in mind. So osteomalacia has to do with the actual building of the bone. Osteoporosis, the bone is already built. I think that's weakened over time. We also have an increase in fractures because the bone is not built properly. The outer layer or the cortex of the bone may appear more dense, next to the lack of density in the medullary bone. So causes, again, vitamin D deficiency, either in diet or the inability of the body to absorb vitamin D. Symptom-wise, you're going to see bowing of bones and fractures. Radiographically, you're going to have that loss of bone density, thin cortex, and the outer edge of the bone will not be very uniform. So here, you see thickening of the periosteum down here at the pelvis. Essentially, it's a callus formation. See almost pseudo-fracture, so it kind of looks like a fracture right through here. It's not a fracture, it's just the way the bone has been calloused over it and built. So here you can see it again. Right here in the pelvis. So here are the vertebral bodies. See how it looks like it has two cortex, cortical lines, essentially. So the outer edge appears more dense due to a lack of the density in the medullary cavity. Essentially, this is causing an increased trabeculation of the spongy bone, which is why this is less dense than the cortical. So rickets, again, is the childhood form of osteomalacia. It is a systemic disease that develops usually between 6 months and 1 year. And again, it is due to a vitamin D deficiency. It is typically seen in the fastest growing portions of bones, where it's first visible in the sternal ends of the ribs, the proximal ends of the tibia and humerus, as well as the distal ends of the radius and ulna. You're going to end up seeing a cupping and fraying of the metaphysis, an overgrowth of non-calcified tissue will be visible as well. Essentially, there will be an increase in distance between the ossified portion of the epiphysis and the end of the shaft. So again, see the fastest growing bone, the sternal ends of the ribs, proximal tibia, proximal humerus, distal, radius, and ulna. So here is a normal X-ray. See how nice and smooth the edges are. Here you can see that cupping, fraying of that distal end of the femur. Here you can see that cupping and fraying as well. You're also going to see the overgrowth of that calcified or non-calcified tissue. So you have an increase in the distance here between the ossified portion. So this, you can see how it's kind of dark as well, ossified here. And there's a larger gap here. Typically, you don't see that big of a gap. You can't really see it in the yeah, kind of in the hip. I don't know if you can see it very well from there. You can see how that area is nice and thin and close, but the gap is way bigger here. This before treatment, you can see some of that cupping here, fraying to the edges. And then after treatment, see how it's nice. A little bit of cupping here, but you can see it looks a whole lot better after they started doing the vitamin D treatments and help that bone. So treatment again, vitamin D integration, and then calcium supplements to help that bone regrow. Finish up with gout. So gout, essentially, when there's too much uric acid in the blood, either by creating too much or not being able to get rid of it. Acute means there's essentially one attack in one joint. So an acute attack of gout would be a buildup of uric acid, let's say, in this joint. A chronic gout means there's recurrent attacks in multiple joints. So it'll be occurring in all of your joints. So essentially what it is, it's urate crystals, or the uric acid buildup creates crystal formation in the joints, joint spaces, in the actual cartilage, and in the kidneys. There can be inherited or reactive gout. So inherited means you get it inherited from your parents. Or reactive means that it's either caused by other diseases or treatment processes that you undergo. Tophi is just a buildup of chalky material that form lumps below the skin near the joint. So if you remember, rheumatoid arthritis, when we took the images, you saw the bumps on the hand and whatnot when the excess fluid was building up. Tophi are kind of the same thing, but with gout, it's actually a buildup of chalky material that then forms those lumps for So symptom-wise, you're going to have some severe extreme joint pain. You're going to have swelling at the site and very warm and red joints. So here, you can see the foot looks pretty normal. Here you can see the swelling and redness throughout the foot. So radiographically, it's usually going to affect the first metatarsal phalangeal joint first. The urine crystals are radiolucent. You can start seeing something here. On CT or even MR, you're not really going to see them on X-ray at all. So you're going to see a lot of inflammation throughout the area. You can see all the soft tissue swelling. You're going to have what we term rat bite erosions. You can see it right here. They turn it that way so it looks like a rat just took a bite right out of the bone. Calcium deposits, or calcium collects in those tophi regions, so it does those little chalky collections. Those will be radiopaque. You will be able to see uric acid stones in the kidneys. You also see that joint space narrowing. Here, this has been going on for a while, so there's really no joint space left. You're also going to see that fibrous ankylosis. So treatment-wise, you're going to do anti-hyperuremic drugs to help reduce the production of that uric acid. If it goes untreated, you're going to have severe joint damage, renal damage, and renal failure. So here, see that rat bite erosion. Here you can see that joint space narrowing. Erosion of the bone here. That has eaten away all the bone and is pretty much destroyed. All right. We'll end there for today and pick up with tangents and the rest of chapter 4 after. Any questions on any of this stuff today?